Hello, my name is Jason Arthur. I'm a clinical faculty member at the University of Arkansas for Medical Sciences. Thank you for the opportunity to present our research, clinical predictors of endotracheal intubation in patients presenting to the emergency department with angioedema. This research was a collaboration between the University of Arkansas for Medical Sciences, University of Florida College of Medicine, Jacksonville, and Hennepin County Medical Center. This study was designed to identify predictors of a need for intubation among patients presenting to the emergency department with a clinical diagnosis of angioedema, to develop a risk score to augment clinical gestalt of a need for intubation, and to internally validate this score. We retrospectively identified all charts with ICD-9 and 10 codes for angioedema among patients who presented to the emergency department of a single tertiary hospital between November 1st, 2012 and August 31st, 2017. Charts were then individually reviewed by research assistants and study investigators to verify the diagnosis of angioedema and thereby confirm inclusion in the dataset. We identified 594 cases, including 103 cases where intubation occurred. Research assistants then reviewed each chart and extracted demographic information, comorbidities, historical factors, outpatient medications, the season of presentation and the day of the week of presentation, symptoms, time from symptom onset to evaluation, progression of symptoms, clinical signs, and details of intubation if and when it occurred. We then divided these cases in a random fashion into a training set consisting of 75% of the total, 446 cases, and a test set consisting of 25% of the total, 148 cases. Using the training set, we screened for candidate variables to include in a multivariate model by excluding variables with p-values greater than 0.15, as well as categorical variables with very low or very high prevalence. Then, using the Spearman correlation coefficient to define a dissimilarity matrix, we performed hierarchical clustering to limit candidate variables containing redundant information. We subsequently applied a multivariate logistic regression using the least absolute shrinkage and selection operator method to reduce this model, and then use standard logistic regression methodology to calculate parameter estimates for the final model. Using the final model parameter estimates, we created a score, which we then scaled and weighted before applying the score to the test set. Factors that were included in the final model included shortness of breath with an odds ratio of 3.12, a history of hypertension with an odds ratio of 5.53, the presence of anterior tongue swelling with an odds ratio of 3.48, the presence of pharyngeal swelling with an odds ratio of 8.98, and the presence of drooling with an odds ratio of 8.76. We assigned points to each of these, with shortness of breath, hypertension, and anterior tongue swelling each receiving 2 points, and pharyngeal swelling and drooling each receiving 4 points. Below you can see the distribution of scores among both the training and the test set. This table demonstrates the area under the curve for the ROC curves based upon the total scores. The area under the curve for the training set was 87.55 with a confidence interval of 83 to 91, while the test set was 86.11 with a confidence interval of 77 to 94.6. Here you can see the ROC curve for the total score among the training set, and then here is the ROC curve for the total score among the test set. With this in mind, we proposed the following cut points. 0 to 4 points we considered low risk, 5 to 7 we considered moderate risk for intubation, and greater than 7 we considered high risk for intubation. And then we applied those scores to both the training set and the test set. Our training set, low risk scores had intubation occur in 3.4% of cases, while in the test set, the low risk had 5.1% intubated. Similarly, in the high risk scores among the training set was 72% intubated, and the high risk among the test set was 78% intubated. So relatively similar. Our conclusion is that a simple scoring algorithm can be used as an aid to predict angioedema patients at risk for intubation. However, we would caution that additional external validation, preferably prospective validation, is necessary prior to clinical implementation. However, this score is promising as a tool which can augment clinical gestalt for physicians assessing patients with angioedema. Thank you very much.